Hi, I'm Tom Bagwell, and welcome to Hello Health, a partnership with the Ochsner Health System and Humana to bring Ochsner's Hello Health weekly education and information series to you. Our topic this week, lung cancer, and our guest is cardiothoracic surgeon Brian Pettiford. First, some background. Dr. Pettiford is a Georgia native. He attended medical school at the University of Pittsburgh School of Medicine, where he also did his internship and residency work before earning his fellowship in cardiothoracic surgery. Dr. Pettiford is board certified by the Society of Thoracic Surgeons and the Southern Thoracic Surgical Society. We should also mention, as we have during his past two appearances, that Dr. Pettiford spent a short time in the U.S. Navy Reserve Medical Corps, and we thank him for that service. And it is our pleasure to welcome back to Hello Health, Dr. Pettiford. Great to have you with us on the program.
Nice being here, Tom.
And good to see you. So let's start off with, how common is lung cancer?
Lung cancer is extremely common. In 2015, it was estimated there were nearly 400,000 Americans living with lung cancer. Annually, there are nearly 225,000 new cases of lung cancer diagnosed. That's based upon 2014 data. In 2007, there were around 215,000 new cases. So there's actually been a slight increase in the annual incidence of new lung cancer cases.
What are some of the economic costs of lung cancer?
They're profound. In 2010, the lung cancer-related care, the cost of that lung cancer-related care was $12.1 billion. And nearly triple of that, $36.1 billion, was estimated to have been lost in terms of those persons who have died and losses due to loss of wages. And that's just lung cancer alone. That does not account for cardiovascular disease and cerebrovascular disease such as stroke or even head and neck cancer. So lung cancer alone is certainly proven to be quite costly.
When I ask you what is the cause of lung cancer, Ochsner certainly gets some credit for that.
It's quite ironic. In the 1940s, Dr. Alton Ochsner, along with Dr. Michael E. DeBakey and Dr. DeCamp, Peter DeCamp, established the link between smoking and lung cancer. Interestingly, it was not too popular, as smoking was socially acceptable at that time, and so Dr. Ochsner was actually considered a heretic by many.
Mm. And we don't know all the reasons, right? Environmental is also a factor, right? Beyond just lung cancer, because as we're going to talk about in this program, some people who get lung cancer haven't been smokers.
Yes, there are certainly some purported environmental causes, but by and far 80 to 90% and closer to 90% of all cases of lung cancer are smoking related, whether directly or indirectly.
Why does smoking cause lung cancer?
There are over 5,000 chemicals, depending upon what you read, 5,000 chemicals in cigarette smoke, 70 of which are known carcinogens. So those are substances that have been proven to directly cause cancer. Some of them include arsenic, benzene, cadmium, the same substance that lithium-ion batteries are made from, formaldehyde that is used in embalming, nitrosamines, which are widely known to cause gastric and esophageal cancer, and polonium.
Since your last appearance on this program, the Surgeon General declared vaping as an epidemic. What do you want our viewers to know about the dangers of vaping?
While vaping is not necessarily considered to be a form of smoking, we don't yet know the ill effects of vaping. We're too early within the realm of vaping to know the adverse effects. My concern is the unknown and the fact that many of the people who are vaping are many of our children and young adults. So I think that within the next 10 to 15, maybe 20 years, we may see some of the ill effects of vaping. And it may even be proven that those effects may be even more profound than those associated with cigarette smoking.
What if I don't smoke or haven't smoked? Are we all at risk?
There is some risk associated with persons who don't smoke at all. And again, that's due to secondhand smoke, third and even fourth-hand smoke. And there are, as we mentioned earlier, some environmental causes. Now, lung cancer, as it relates to smoking, has no respect for person. It has no respect for neither celebrity nor wealth.
Let's show people some of the folks who have died from lung cancer related to smoking.
Yes. The first image shows Walt Disney, who obviously was one of the richest men in the world, and that did not save him from the ill effects of smoking. Peter Jennings, a well-known newsman on ABC News. Sammy Davis Jr. Ironically, this entertainer who used his voice to entertain many died due to throat cancer, another well-known cancer that is smoking related. And 5 of the actors who acted as Marlboro Men died from smoking-related lung disease.
We talked about the economic costs of lung cancer and smoking. What about just hyper-focusing on the state of Louisiana?
There certainly is a significant cost related to smoking in the state of Louisiana. 6,200 people die annually within the state of Louisiana from smoking. And it also affects people below age 18. As I mentioned just a few moments ago, a significant number of people in Louisiana, nearly 800 people, die from the effects of secondhand smoke. And you have to also remember that Louisiana is one of the poorest states in this nation. And so those effects are exponentially worse than in other regions of the country.
Mm. When we think of smoking, we think of damage to the lungs, but as you well detail, but we need to be thinking beyond that, right? That smoking can cause real problems for the rest of the body.
Yes, indeed, from head to toe. Smoking increases your risk of stroke. There's a substantially increased risk of stroke, and interestingly, those individuals who stop smoking for approximately 5 years actually lessen their risk of a stroke that's almost commensurate with someone who's never smoked. There's an increased risk of head and neck cancer in individuals who smoke. There's an increased risk of cancer of the mid portion of the esophagus, and esophageal cancer is nearly as deadly, if not more deadly, than lung cancer. There's an increased risk of gastric cancer in people who smoke. There's also a significantly increased risk of pancreatic cancer in individuals who smoke.
Certainly one of the deadliest cancers. What about, you didn't mention heart disease, but if I'm not mistaken, cardiologists are on this program warning people. That's the first thing you should stop.
I would be remiss if I did not mention the association between cardiovascular disease and cigarette smoking. Each time you smoke a cigarette, your coronary arteries, those are the vessels that provide nutrients to your heart, they go into spasm. They decrease their diameter. And as a result, you have a decreased amount of blood flow to the heart. Your heart rate increases. So there are some extremely important and deleterious effects of smoking, direct effects of smoking that are immediate as it relates to heart disease. It also causes hardening of the arteries, not only the arteries within the heart, but the arteries throughout your body. Some people who have a long smoking history actually lose tissue in their feet due to poor blood flow, and it's all related directly to smoking.
People have known everything you've said for a while now. You've done a really good job of reminding them of that. But so why doesn't everyone just quit? And it's not that easy.
It's not that easy. It's an addiction, just like any other drug. It is a drug, and that drug is nicotine. And some studies have shown that it is more difficult to kick a smoking habit than it is to kick an opioid habit. Smoking, the nicotine within cigarette smoke is actually 10 times more addictive than heroin, which is a highly addictive drug, as we know.
I think I know what secondhand smoke is, but as we were talking before the program, there's also a third-hand smoke and a fourth-hand smoke. So remind us about secondhand smoking, third and fourth-hand smoking, and why they're maybe not just as dangerous, but maybe so.
Yes. So secondhand smoke is also known as mainstream smoke, and that is the smoke that a smoker exhales. Obviously, some of the tar and other cancerous components of cigarette smoke are deposited within the smoker's lung tissue, but some of that material is also exhaled, and for someone who's standing by, they could possibly inhale that material.
At the bar, at a restaurant, before we started enacting some of these laws, right?
Absolutely, or a poor child who lives in a household where the parents or other adults smoke heavily. There's also something known as side stream smoke, and that is third-hand smoke. That is the smoke that comes off of the tip of the cigarette while the cigarette is burning. It is believed that the tar content in that is probably higher than that associated with secondhand smoke. Now, the data is not as clear as to the relationship between exposure to the side stream smoke and lung cancer, but the components, the tar and other carcinogens within that material is definitely higher than that associated with mainstream smoke.
And then fourth-hand smoke.
Fourth-hand smoke. Again, the data is less clear as to the causation between exposure to fourth-hand smoke and lung cancer. However, when a person exhales cigarette smoke or the cigarette smoke burns off of the tip of the cigarette, it eventually will settle as particulate matter on inanimate objects, maybe the surface of a table or counter, and as you walk past that structure, it will be stirred. That particulate matter will float up into the atmosphere and could be inhaled.
Why is lung cancer so deadly?
It is deadly because it is difficult to diagnose early. Up until recently, up until 2011, as a matter of fact, there were no significant and reliable means of screening patients for lung cancer. There was a large study, it was a nationwide study called the Lung Cancer Screening Trial, whereby we were able to identify specific age groups amongst smokers who were at increased risk of developing lung cancer. And as a result, certain people will qualify for a low-dose CT scan, and we're hoping that that can translate into an earlier diagnosis and hence a much improved survival. That will take several years before we can realize that, that favorable outcome.
What would you say to the young person who says, yeah, by the time I'm an adult, they'll have that thing figured out and I won't have to worry about it?
I would tell that individual that he or she is gambling with their lives. And we're talking about one aspect, and that's lung cancer. That does not mention all of the other deleterious effects of smoking. Again, cardiovascular disease, cerebrovascular disease, head and neck cancer. I would strongly encourage them to just avoid smoking altogether.
Our guest this week is Dr. Brian Pettiford, and we're talking about the dangers of smoking, including lung cancer. So you talked about the difficulty in screening. So how is lung cancer diagnosed today?
It is diagnosed in several ways. For the lucky patient who comes in for some other unrelated issue, maybe they're undergoing a shoulder surgery and they get a preoperative chest X-ray. It is not uncommon for those individuals to have an incidental finding of a spot in their chest, and that leads to the workup. Many patients, unfortunately, present with symptoms. Those symptoms can involve a cough, or a nagging cough, or sometimes they present and they're coughing up blood, or they've had profound weight loss, or they might have weakness or some other neurologic sign and or symptom. And in those instances, it usually is indicative of an advanced disease state. So chest X-rays, CT scans, and another type of X-ray or radiographic study called a PET scan are all used to diagnose and stage patients with lung cancer.
We should point out there are different types of lung cancer, right?
Yes, there are different types of lung cancer. There are two broad categories, non-small cell lung cancer and small cell lung cancer. And within the non-small cell lung cancer, which by the way is the more common of the two broad categories, there are multiple different subsets. The more common forms of non-small lung cancer are adenocarcinoma and squamous cell carcinoma. Non-small cell cancer accounts for about 80 to 85% of all forms of lung cancer, and small cell lung cancer, fortunately, only accounts for 15 to 20%. And I say fortunately because it is an extremely aggressive form of lung cancer. It is so aggressive that usually surgery is not performed for any reason other than diagnosing the disease. It is usually treated with chemotherapy.
I know you wanted to spend just a little bit of time talking about mesothelioma as well.
Yes, mesothelioma is known to be caused by asbestos exposure. So individuals who worked in shipyards, people who served in the Navy on ships, even auto mechanics who worked around a lot of brakes and brake dust are exposed to asbestos fibers and can develop malignant mesothelioma. It is a cancer of the lining of the chest cavity and the surface of the lung.
I think we can show our viewers too what mesothelioma cells look like under a microscope.
Yes, this is an electron micrograph, and it shows the different types of malignant mesothelioma. The more common type is epithelioid. Malignant mesothelioma is a serious disease. Epithelioid is the less virulent or less aggressive of the two. The other is sarcomatoid, and then there's a biphasic or mixture of the two, the mixture of the epithelioid and a sarcomatoid malignant mesothelioma.
We've also got some other images to share with our viewers of what mesothelioma looks like, and obviously very, very dangerous, right?
Very dangerous, and the difficulty with malignant mesothelioma, similar to lung cancer, it is difficult to diagnose early and extremely difficult to eradicate surgically. Usually we perform what we call multimodal therapy, meaning a combination of surgery and non-surgical forms of medical therapy in an effort to treat malignant mesothelioma.
So let's talk in general how lung cancer is treated.
Yes. In general, first of all, lung cancer is diagnosed and it is staged. And so the stage will dictate the form of treatment. If it's an early stage lung cancer, usually surgery alone is effective and may in fact prove to be curative. For medium stage lung cancer, it usually involves a combination of surgery, chemotherapy, and/or radiation therapy. Sometimes the medium and advanced stage lung cancer only will be treated using chemotherapy plus or minus radiation therapy.
What are we looking at here, doctor?
This is an example of this is a CAT scan image, and it shows a spot on the left of the screen. That's the right lung. So the patient's lying down on a CAT scanner table, and that's an individual slice. The black on the CAT scan on this image is air, and so you have the air in the lung, and the smaller circle in between the two larger circles is the windpipe. And there's a white dot located in the back on the left side, and that's an example of a lung nodule. We call those lung nodules or small lung mass.
There are different types of lung cancer surgery. We're going to talk about all the types in just a moment. But first, Dr. Pettiford is going to walk us through robotic lung cancer surgery. Let's take a look.
Today's patient is a 70-something-year-old woman who has a newly diagnosed lung cancer within the lower lobe of her left lung. Today, we performed a robotic left lower lobectomy, and we also performed a mediastinal lymph node dissection. There are different ways by which you can perform lung removal. There are two broad categories: open and minimally invasive or closed. The minimally invasive approaches, including VATS and the robotic-assisted approach, are associated with much less blood loss and a faster return to normal activities of daily living. The robot, it's a platform that has arms attached to it. And what we do is we make very small incisions, usually somewhere between 8 millimeters to 12 millimeters, so relatively small incisions. We insert stainless steel instruments into those incisions. So those instruments serve as portals into the person's chest, into the patient's chest cavity. We then attach the robotic arms to those portals, if you will, and we insert our instruments through those portals and into the patient. The robotic arms then respond to movements that the surgeon makes at the operating console. The robotic platform and several assistants stand around the patient's operating room table, while the surgeon and his or her assistant sit across the room and control all of the functions of the robot. The robotic approach, again, allows us to perform this surgery with a much more detailed and accurate dissection of tissues, less tissue injury. That translates into much lower blood loss and a much faster recovery time for patients.
We saw a lot of people there in the operating room, and I know you wanted to touch on, and this is very different than a lot of operations where everyone's around the table. In this case, you're all over the place.
Yes, in the robotic surgery, we do have our assistants and the anesthesia team are centered at the patient's bed, along with the robotic platform, and that's certainly evident here. The surgeon and the surgeon's surgical assistant are actually removed from the operating table. We sit at a console and we actually look inside of the console. And what we see is an image of the operative field that's magnified 10 times what the naked eye can see, and it also is in 3D. and the surgeon controls every movement of the robot. It's also an excellent training tool for many of our trainees because that individual sits at a console adjacent to the surgeon and can see what the surgeon is also seeing and doing.
That's one type of surgery. Talk to us about the others.
Yes, there's another form of minimally invasive lung surgery called VATS, and the image on the left shows an example of a VATS surgery where we make small incisions, and the difference between a VATS and a robotic approach is that the surgeon, with respect to the VATS surgery, stands at the patient's bedside. We still have a scope that is attached to a camera, and it projects an image on a video monitor. So while we're working, instead of looking down at the patient, we're looking up at a screen. There's also, and this shows an example within the operating room of just that. The other image showed a thoracotomy, which is the open approach. We generally reserve that approach for patients who have very large, bulky tumors that have a lot of enlarged lymph nodes, and individuals that we operate on for malignant mesothelioma.
What is the prognosis for a patient diagnosed with lung cancer today?
Very good question, Tom. A lot of that is predicated upon the stage of diagnosis. Obviously, earlier stage patients will have a much better prognosis, and it also is related to the actual histology or type of lung cancer. For the most part, patients with stage 1 disease have a 5-year survival, and there are different types of survival. One is called disease-free, the other one is called overall survival. But with respect to overall survival, for patients with stage 1 disease, the survival's close to around 60%. Some individuals, it can actually be closer to 80%. For stage 2, there's a significant drop-off, and that drops off to around 40%. For stage 3, there's a precipitous drop in survival, and that's around 15%. And there's a very low, if any, survival for those unfortunate individuals who have stage 4 or metastatic disease.
Give us some hope. Talk to us about advances being made or advances you see coming the next time you're on this program or the next time after that.
Yes. The one thing that we're all excited about in healthcare is lung cancer screening. Again, there has not been any effective screening tool for determining whether or not an individual has lung cancer, and I think that the low-dose CT screening will be a game changer. The key is getting the public and many practitioners, healthcare practitioners, to understand that this technology is available for those who qualify. And so CT screening is one modality that will certainly decrease the number of people who succumb to lung cancer. There's another form of therapy called stereotactic body radiation therapy. That's a mouthful, but that's a specific form of radiation therapy that we use for specific tumors, tumors that may be deep and completely surrounded by lung, or an individual who may have a small lung cancer but may not be a surgical candidate. Maybe their lung function is so poor that they can't tolerate surgery. Maybe they have some heart disease that makes them not a surgical candidate. In those individuals, this SBRT it's almost like a laser-guided missile. It hits its target and there's very little collateral damage to the surrounding lung tissue and other structures, as opposed to traditional external beam radiation where it's almost like carpet bombing. Yes, it hits the target, but it destroys a lot of the native lung tissue and also does damage to some of the adjacent tissue. And so SBRT definitely has a role in selected patients. And then from my perspective, lung conserving therapy. Not everyone has a significant amount of lung taken out. Sometimes we take out less lung than we would ordinarily take out, depending upon the cancer size as well as the person's underlying medical condition.
Any requirements for the CT scanning you talked about? Yes,
in general age, the person has to be 55 to 74 years old. They have to have a 30-pack year smoking history. Now, what that means is that they have to have smoked at least 1 pack per day for 30 years or 2 packs a day for 15 years. So those two numbers, you multiply them and you should come up with 30. And they have to have engaged in smoking cessation for at least for around 15 years or less. in order to qualify for this study. Now, the age and smoking requirement can be altered if an individual has some other disease process in addition to the lung cancer. There are in addition to the smoking. There are select disease processes that will allow us to qualify even more individuals.
And what about some of those smoking cessation therapies?
Yes, there are some pharmacologic or drug-related smoking cessation therapies, and there are others that are not smoking-related or drug-related. A more commonly used is the nicotine gum or nicotine patch. There's another form of pharmacologic therapy that's extremely effective, but has an extremely profound side effect profile, and that's Chantix. For those individuals who can tolerate the side effect profile, and there are some significant side effects, if they can tolerate the side effects, I think patients who are able to comply with Chantix therapy probably have the highest rate of smoking cessation and successful smoking cessation, meaning that they don't return to smoking. E-cigarettes, obviously, with all of the recent articles out there about exploding e-cigarettes and concerns about some of the chemicals that are contained within e-cigarettes, I'm not really quite yet ready to place a stamp of approval on e-cigarettes.
And I know Ochsner is there to help some of the people who would most benefit from these cessation programs.
Yes, indeed. Ochsner participates in the Smoking Cessation Trust. This program allows for patients to receive pharmacologic therapy, some of the therapy that we mentioned previously, as well as smoking cessation counseling.
Dr. Brian Pettiford, thank you so much for being here. My pleasure, Tom. Thank our guest for the education and information he has provided tonight, or for our program, and for his work in the Ochsner Health System. To make an appointment with any Ochsner physician, including this week's guest, or to register for any of Ochsner's Hello Health seminars, you can call Ochsner at the number you see on your screen, or send us an email. Here's our address, hellohealth@ochsner.org. As a reminder, you can rewatch this week's presentation or many of our other Hello Health programs on Ochsner's website at ochsner.org. Just type Hello Health in the search box. Our thanks again to this week's guest. Thanks to Humana and Ochsner for making our program possible. And our final thanks, as always, is to you for your support of this program, Hello Health. We'll see you next time.